කවිඳු ඇහෙනව නේද? ඇහෙනවනේ පොඩ්ඩක් මේ පොඩ්ඩක් සිග්නල් මදි මේ අපේ මේ ටවර් එකේ මොකද්ද ට්‍රාන්ස්ෆෝර්ම එකක් හරි මොකක් කර ගිහිල්ලාකෝ ඇහෙනවනේ ක්ලියර්ට ඇහෙනව නේද? ඇහෙනවනේ. හරි. ඒක තමයි පොඩ්ඩක් සිග්නල් අඩු ගතියක් තියෙන එක. හරි පටන් ගමුකෝ. yes who will start number 28 නේ. yeah so what do you think the answer is? Yeah, so can't it be yeah, can't it be a partial seizure? So how do we how do we classify seizures? Now the classification has been changed, right? So you should know the current classification of seizures in pediatrics. Anyone? Yeah, how do we, broad classification, right? Not the fine tune things. How do we classify things? Yes, we'll ask who are doing pediatrics now. Anyway, now we have started the Profinit neither. How the pediatric run? Anyone here? Pediatric either? Okay, right. Uh, yeah. Usually initial classification එකේ තමා තිබ්බේ මේ අර simple කියන්නේ generalize partial කියලා බෙදලා partial එක ආයෙ බෙදලා මේ simple partial complex ඔහොම කියලා classification එක දැන් ඒක යන්නේ නැහැ. අපි දැන් classify කරන්නේ generalize or partial, that's all, right? So the generalized කොටට තමයි ඔය generalized tonic 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 එකේ ඉන්නේ clonic myoclonic Then what absence seizures and all. Partial occipital lobe epilepsy, partial epilepsy, ඒටික තමා මේ partial epilepsy there are things right like that are simple partial sim sorry partial simple partial complex කියලා දැන් බෙදන්නේ all are partial conversions right so partial conversions they can also have some staring episodes, right? So, I mean, here the answer is absent seizure, but remember, partial seizures can present with automatism, right? So, automatism could be verbal, or it could be motor, or could be sensory, right? So, there are not the staring episodes, but they can have some auras, right? Maybe you have heard of Dijau, Jamisu, Kilatino, right? So, go and read about those things. So, ඔය සාමාන්‍ය ප්‍රශ්න අහන තැන. Right? Okay. So what is the characteristic EEG finding in absence seizure? You should know, right?
3 spikes and waves per minute.
Yeah, 3 spikes and a hertz, 3 spikes hertz and yeah. So how do we treat absence seizures? What is the drug of choice? What is the drug of choice in absence seizures? Yes, Shakti. Yes. What is the drug of choice?
Ethosuximide.
I can't hear. Yeah, you are correct. Yes.
Ethosuximide.
Yeah, ethosuximide is the drug of choice, but here in clinical practice, what we use is the valproate, right? So, yeah, ethosuximide is the drug of choice, but here in Sri Lankan setup, the first line is sodium valproate, and we don't use carbamazepine in generalized conversions, right? Mainly absence seizures, right? Absence seizures ගැන තව දැනගන්න ඕනේ. There are typical absence seizures and atypical absence seizures, right? So atypical absence seizures, they can have some myoclonic activity or floppiness. There can be a tonic-clonic movements as well, apart from the staring episodes, right? Typical absence seizure is only having that staring episodes. Okay. Yes, next thing 29. Yes, Sachit නේද කරන්නේ? Borderlands, yes. කොහොමද? Sorry, right? I got a call from the ward. Right, okay. ඇහෙනව නේද කවුද මේ කවින්දු? Right. කවුද කරන්නේ? 29.
Okay, so if Sajid is not there, I'll do it. Shakti here. A
Yeah.
9-year-old Healthy boy presented with fever for 1 day and 5 episodes of vomiting. There is no history of head trauma. He was drowsy and his GCS was 7. Respiratory rate 10 cycles per minute. He was pale and CRFT was 2 seconds. He was floppy with absent deep tendon reflexes. What is the next appropriate management? So, although I only looked at one thing here, that was that GCS was 7, and I considered that below 8, if the GCS is below 8, the respiratory tract might not be patent, therefore we might need to intubate and ventilate. So I took that answer as the correct one. I'm not sure whether that's true.
දැන් ඉතින්
Because
දැන් ෆයිනල් ආවම I'm not sure කියන්න බෑ, right? You should be sure about yourself. Right? Right? Shakti? I am not sure කියන්න බෑ. Now you are almost like at the finals. Okay.
no, my problem was his GCS was 7, but then
Yes.
his respiratory rate was 10 and CRF.
Yeah. So what do you think about the respiratory rate? 10 means he's almost like apneic, no?
Yeah, true.
Yeah, again, 9-year-old එකෙනෙක්ගේ what is the normal respiratory rate? Should be around 24 like ne? So
Yeah.
24, 25, that much. So if the respiratory rate is 10, that means almost child is in respiratory failure, right?
Yeah.
So your answer is correct, right? මං කියන්නේ ඒවා doubt තියෙන්න බෑ. Those are very simple things. So we can't give a bolus because we have to go through A, B, C, D, E. So first thing we have to do is to secure the airway. So we have to intubate and ventilate. Yes, we have to do the rest of the things as well. Fever for 1 day and vomiting for 5 days could be meningitis. Could be meningitis. So we have to give cefotaxime, and because of meningitis can be complicated with cerebral edema, so we can give a 3% saline. And because of the poor perfusion, yes, we have to give bolus sometimes, and we have to arrange CT as well. All are correct, right? So the first thing is the airway. So as he said, the answer is D, intubation and ventilation. Then we have to go through the rest of things. Yeah. So yes, then meningitis in a 9-year-old boy. Wait, තාම ඉඳින්න එක. කමිනු යන්න බෑ. Yes. So what are the possible etiology for the meningitis? 9-year-old boy. What are the possible infections you would think of? Yes, Kesher is there, no? 9-year-old boy presented with meningitis. So what are the organisms that you want to think of?
Group B streptococcus.
Yeah, group B streptococcus. Yes, streptococcus pneumoniae. Yeah. Then what else?
Then Haemophilus.
Hemophilus, good, but it's rare, right? 9-year-old, because we are doing vaccination. So after 1 year, hemophilus is rare, but yes, we have to consider. What else?
Meningococci, pneumococci.
Yes, Neisseria meningitis, right? So Neisseria is the thing that we have to think of, gonococcal infection, right? So yeah, those are the things. So if it is Hib, what is the drug of choice? Hemophilus influenza, no? What do we give if you are suspecting hemophilus causing meningitis?
Cephalosporins, third generation.
Yeah, third generation cephalosporins, yes, and pneumonia, no? Yeah, again, it is cephalosporins, right? So that is why cefotaxime is used when we are suspecting meningitis. So broadly, it can cover almost all the things. And for the Neisseria also cefotaxime, but sometimes we use penicillin as well. If you truly suspecting what Neisseria meningitis, right? And if you are suspecting Haemophilus, what are the precautions that we do before starting antibiotics? There's a specific precaution that we apply if we are really thinking of Haemophilus causing meningitis. Yes, Netsar. Oh, Netsar.
Yes.
Yes. So Haemophilus එකක් suspect කරනවා නම් before starting antibiotics, we are giving something to the child. Do you have any idea?
No, sir.
Right. Yeah. Usually we give Dexa, right? Dexa, we are giving Dexa 30 minutes prior to the antibiotics. It's because that with the antibiotic release, that with the Haemophilus they can develop toxicity, right? Ototoxicity and all. Go and read about that thing, right? Dexa for Haemophilus when you are suspecting meningitis, right? Okay. Yes, we'll go to the next thing. Yes, Pabasara or Pabasara. මට ඔයා කියන එක නම් පොඩ්ඩක්වත් ඇහෙන්නේ නැහැ. Yes. මට විතරක්ද ඇහෙන්නේ නැත්තේ අනිත් අයටත් ඇහෙන්නේ නැද්ද? I don't know because
Sir,
I
I'm
also
Chetika.
have some.
My question is, sir, I'm Chetika.
Yeah. Oh yes, Chetika.
Sir, I'm Chetika. My question
Yes.
is SBA 24,
Yeah.
3-year-old baby with tetralogy of Fallot presented with 2-day history of fever and vomiting. On examination, she is drowsy and lower limb reflexes are exaggerated. What is the most appropriate next step in the management?
Yeah.
So, sir, this boy is having a tetralogy of Fallot. So, as a complication of tetralogy of Fallot, he can be having infective endocarditis. Also, endocarditis, he can get brain abscesses. I got the answer as CT brain.
Yeah. So yes, in tetralogy of fellow, as for final years, you have to remember two things: the more complications, right? First, one thing is the cerebral abscess. Other thing is cerebral thrombosis. Both can be happen, right? But here the history is with the history of fever and vomiting, so could be cerebral abscess. So yeah, cerebral abscess with edema, right? Because child is drowsy and lower limb reflexes are exaggerated. So what is the appropriate next step in the management? Yeah, they are asking the next step Yeah. So echocardiogram, usually it's not the next step. Lumbar puncture is out because we don't do lumbar puncture when we are suspecting something up in the brain, right? So that is also not correct. So full blood count, what do you think? Full blood count, CT brain and blood
We should
culture.
do yes, sir. We should do a blood culture, and full blood count also. But as this question asked, what is the most appropriate next step, and also blood culture and full blood count, any pathology in brain.
Yeah. So you are there, right? Yes. B, C, and D are correct. All are correct because we have to do the blood culture, we have to do CT brain and full blood count. So, but since the child is drowsy and low limb reflexes are exaggerated, what we urgently do is the CT brain to rule out cerebral abscesses first. But at the same time, you have to take the blood cultures and start with antibiotics. And with the cultures, we have to take the full blood count. So, what are the things that you would anticipate in a full blood count of this child? Yeah. Etiology of fallow with fever and vomiting. And what are the abnormalities you would expect in full blood count? Yes, Gayatri.
There would be
Go then.
sir, there would be neutrophilic leukocytosis.
Yeah,
Uh,
WBC count and neutrophil count will be high. Yes. What else?
Polycythemia could be also be there because it's cyanotic heart disease.
Oh, polycythemia කියලා එකක් full blood count එකේ පේන්නේ නැහනේ.
The
Yeah,
RBC
what are
count.
the things? Yeah, RBC count is high and hemoglobin count would be high, right? Yeah. Then what else? Platelet. What do you think? What will happen to the platelet in a child with cyanotic heart disease? මවක කියලා දුන්න. Right? So maybe the one we'll see who can remember. Yes, Gayatri. Yes.
I'm not sure, but platelets can also be high because the hypoxia induces erythropoietin secretion, and there's a reactive thrombocytosis along with the erythrocytosis.
Yes. You can't make theories, right? Right. මම කියලා දුන්නේ I think for your group. So Gayatri line group එකට තමයි. Or to the second group. Why the cyanotic children get thrombocytopenia, right? So usually cyanotic children they are having some thrombocytopenia, right? So there's a reason for that. මම ඔය කියලා දුන්නා එක group එකට. I can still remember. Yes, Aditya, were you in that group? No.
No, sir.
ඔය ඉතින් හිටියත් නැහැ කියලානේ කියන්නේ නේ. Yes. Yes. Anyone? Why cyanotic heart disease children get thrombocytopenia? That's for the Shakti Hitam group. Yes. I can remember now. Shakti and second group. Yes. And maybe the first group also. Yeah, what happens is megakaryo lung is one of the place for the megakaryopoiesis, right? Again, thrombo platelet හැදෙන එක තැනක් තමයි මේ lung එක. So in cyanotic heart disease, usually the blood circulation is bypassing the lung. මොකද mixing එකක් වෙනවානේ. So megakaryopoiesis එකක් වෙන්නේ නැහැ. So they are usually having thrombocytopenia, right? Not thrombocytosis, right? Yeah, okay. We go to the next thing, 28.
My question. So am I audible?
Yeah, I can hear you.
My question is, there's a 3-month-old baby on IV ceftriaxone for acute bacterial meningitis for 5 days, and he has
Yeah.
developed fever and irritability after being afebrile for 2 days. The question
Yeah.
asked is, what is the next most appropriate management for this baby? As I think this baby has meningitis, and when give a meningitis when we give antibiotic, it will cause the destruction of bacteria, and it causes release of lot of toxin, and it causes cytokine mediated inflammation, and that may cause complication like subdural effusion, like
Yeah.
it is intracranial pressure like things. If I consider answers, we can exclude the IV acyclovir because this is bacterial meningitis, and also answer E, to do a CSF examination, we should exclude the increased intracranial pressure pressed, and when
Yeah. Good. Yeah.
considering with D, repeat blood culture, usually bacterial meningitis is usually preceded by the bacteremia. They should have already done the blood culture and may have identified the organism. When considered answer C, it is a IV change into IV meropenem. It is a broad spectrum antibiotic. I don't think that is not. I don't think it is the most appropriate next step of management.
Yeah. Sometimes it might be needed, but not the next step. Yes.
I use the answer as I choose the answer as D, USS of B.
Yeah. Good, right? Yeah. He has nicely explained the 3-month-old baby with ceftriaxone with bacterial meningitis, right? So what happens is with the that cytokine releases and all, there can be a subdural effusion. So with the subdural effusion, again it can be get infected. With the collection, again there can be a secondary infection. So they can present with fever, or else it can be the abscess formation as well. Sometimes meningitis, if the dose is not correct or whatever, sometimes as a complication, they can develop cerebral abscess. So they can again can have fever, right? Fever with irritability. So first thing we have to do is the ultrasound brain. Since the 3-month-old, if we still can be still open, so we can do the ultrasound brain, and then we have to rule out the CNS complications like subdural effusion or the cerebral abscess. So what is the bedside thing that we monitor in a child with meningitis, 3-month-old child? So 3-month-old child, once we started IV ceftriaxone for many suspecting meningitis, there's a bedside monitoring chart we maintain. Daily we have to measure it and keep it on the chart. What is it? Yes, Prabhasha is there, no? Yes, Navodya. Yes.
That I don't know, sir.
Are you doing pediatrics now?
Yes.
Huh?
Yes.
Yes. So, okay, right. So you have to monitor the OFC, right? OFC එක monitor කරන්න ඕන. Occipital-frontal circumference, right? So in a child with meningitis, especially less than 1 year, what we do is the monitoring of the OFC. So if the OFC is rapidly getting enlarged, we have to think of raised intracranial pressure. Then we have to immediately take the neuroprotective measurements, right? So bedside thing is the OFC to look for the for as a monitoring tool, right? Yeah. And so how long will it take to close the anterior fontanelle? Usually anterior fontanelle එක close වෙන්නේ වයස කීයද සාමාන්‍යයෙන්? How long that we can wait? Anyone? Yes, we can wait up to 18 months, right? So it can be open until 18 months, and posterior fontanelle usually it closes within first 3 months, right? If it is open more than 3 months, we have to think of something abnormal, right? And until 18 months, we can just see whether it can be closed or not, right? So we can reassure and say unless the child is doing well, right? So remember those small things, right? Wahano Samala. And Kavindu, are you doing pediatrics now? So who is the SR now in the general ward? Kaudin ele me yeah, you know. General පැත්තේ කවුද ඉන්නේ SR? දන්නේ? දන්නේ නැද්ද? Okay. My wife will be coming from Monday, right? So to the Profinit. අල්ලගෙන classes ටිකක් දාගන්න. Right. Yeah, we go to the next thing 29.
Saya Chetika.
ඇයි මොක දේවරංගට මොකද උනේ? ව්‍යාස් දේවරංගනා. Yeah, anyway, we'll do. Yes.
4-month-old baby presented with recurrent bouts of bending of head and body forward. EEG shows sharp multifocal discharges in chaotic background of slow wave activity. What is the management indicated? So this baby is having recurrent seizure. It looks like this baby is having recurrent seizure attacks. So it might be due to epilepsy syndrome. So the description of the EEG activities most suitable for the infantile spasms. So the first line management of the infantile spasm is corticosteroids and I can't. and Vibha get
Mona, I can't hear you.
and Vibha getting.
Yeah, bigger battery, right? Bigger battery we don't use unless there's a special indication. So what is the indication to start bigger battery as first line in infantile spasms? Come on.
West syndrome.
Yeah, good, right? Who gave the answer? Aditya, kawuda? Ashan, yeah, good, right? Yeah, very good. Yeah, if we are suspecting West syndrome, yes, we have to start with vigabatrin. So, what is West syndrome?
Syndrome is epileptic syndrome which usually common among the infants between
Can you all hear me? Another,
Yes, sir.
right? Okay. What is the triad in West syndrome? Anyone? Yeah, it's not clear, but it's kini gahunne, right? Hips arrhythmia, developmental delay, and the infantile spasms. So those are the things in the triad of West syndrome. And what is the neurocutaneous syndrome that associate with infantile spasms? Anyone? There's one neurocutaneous syndrome that can coexist with the infantile spasms.
Tuberous sclerosis.
Yeah, good, right? Yeah, good. Very good. Yeah, that is tuberous sclerosis. So, in a child with hips arrhythmia and features of infantile spasm, you have to look for the features of tuberous sclerosis. So, what are the cutaneous features in tuberous sclerosis? Anyone? Yeah. What are the cutaneous things that we see in tuberous sclerosis? The medicine එහෙමත් කරලා නේද ඉන්නේ medicine and you have done dermat appointments. කීයක් දෝ ඉවර කරලා නේද ඉන්නේ? Yeah.
Angiofibromas.
Yes. Angiofibromas, yes. That
Ash
means
leaf.
adenoma. Yeah, ash leaf spots, adenomal sebaceums, ash leaf spots. What else?
Gangrene patches.
Yeah, Chagrene patches, good. There can be
Angular
cavities.
fibromas.
Yeah, periangual fibromas, and there can be capillate spots as well, right? And they can have retinal and brain involvement as well. Anyone who knows the retinal and the brain things? Yeah, brain, they can have subependymal gliomas, right? Subependymal gliomas can be there, and in the eyes they can have retinal phacomatas, right? So go and read about tuberous sclerosis, neurofibromatosis, and Sturge-Weber, right? ඔය තුන අහනවා final එකේ they are expecting you to know those three things, right? Go and read about thoroughly. ඒ කියන්නේ හරියටම කියවගෙන finish ඒක ඉවර කරගන්න. right? නැත්තම් ඕක note එක ගහලා තියාගන්න. මොකද always they put pictures from those three neurocutaneous syndromes. Sturge-Weber, neurofibromatosis type 1 and 2, and the tuberous sclerosis, right? Okay. So yeah, prednisolone is the drug that we use in infantile spasms. What do you call is the UKIS regime, right? That is, we give prednisolone as first line in child with infantile spasms. Yeah. Okay. Yeah. Next. Yeah. Number 28.
So my
Yes,
question
Charlie.
is,
Yeah.
a 7-year-old boy presented with ataxia, diplopia, areflexia, and lower limb weakness. 1 week ago, he had acute gastroenteritis. On examination, there is truncal ataxia and left-sided 6-nerve palsy. What is the best diagnostic investigation for this condition?
Yeah.
So the question is, has more like to be Guillain-Barré disease. However, the Guillain-Barré disease is peripheral neuropathy and usually not cranial nerves are not affected. But in condition called Miller-Fisher syndrome, it can be present as affecting to the cranial nerves, and usual triad of symptoms: ataxia, areflexia, and ophthalmoplegia.
Yeah, good. Yes.
So The question is asking the best diagnostic investigation. I get the answer as nerve conduction study because it is the diagnostic investigation for the Guillain-Barré disease.
Yeah. Yeah, well, his answer is correct and he has nicely explained. Yes, Guillain-Barré is the thing that we think first, but in Guillain-Barrés usually they don't affect. I mean, ophthalmoplegia එකක් එන්නේ නැහැ. So usually when there's areflexia and but things we with ophthalmoplegia we have to think of Miller-Fisher variant. So whatever the thing Miller-Fisher variant or Guillain-Barré, to diagnose that we have to do the nerve conduction studies because it's mainly because of the involvement of the axons, right? ඒකේ axon එකේ demyelinate වෙන එකක් නෙවෙන්නේ, demyelinating disease නේ. එතකොට to diagnose we can do the nerve conduction studies. So what about the answer CSF analysis? Charit, maybe you have now read about the things, ne?
Yes, CSF analysis also can done, and there is isolated protein elevation, but it is
Yeah, good. Yes.
useful after about 2 weeks.
Yeah, very good. Yes, that is the thing that I want to tell you. Lumbar puncture usually we do in a child with Guillain-Barré or Miller-Fisher after excluding the raised intracranial pressure. It's mainly because it's mainly because to get a clue, right? It's not a diagnostic thing. We can see high protein levels. Sometimes leukocytes also can be predominant, right? Leukocyte count is high, at the same time protein would be high. So not after 2 weeks, after 10 days. Yes, 2 weeks is also correct, but usually not within the first 10 days. So what is the other differential diagnosis? Even though it's not rare here, we do precautions. We do notify in a child with acute flaccid paralysis, unless proven otherwise, there's a disease that we have to think of. අපි සාමාන්‍යයෙන් acute flaccid paralysis ආපු කෙනෙක්, whatever, even though the diagnosis is Guillain-Barré, we do notifications, right? මතක තියාගන්න. Right? අපි ඒක notify කරනවා community එකට. In a child with acute flaccid paralysis. Why is that? What do you have to exclude?
Poliomyelitis.
Yeah, very good, right? Poliomyelitis. So even though it's been eradicated, we have to notify for acute flaccid paralysis, and we have to send the stool samples as well, right? For poliomyelitis. ඒක සාමාන්‍යයෙන් කරන කියන්නේ Guillain-Barré management ගැන ගමන් stool samples උත් අපි යවනවා for polio, right? For them ඒක MRI එකට යන්නේ medical research institute එකට තමයි යවන්නේ. We have to send the stool samples, right? ඒක මතක තියාගන්න. Usually අහනවා මේ ඔයාලගේ long case එකේ, yeah, usually in the long case එකේ අහනවා, right? What are the other things that we do here? So notification, sending stool samples, and lumbar puncture after 10 days for further justification of the diagnosis of Guillain-Barré, right? Yeah, good. So what will happen to the CPK levels in Guillain-Barré? Yes, Charit.
I'm not sure. So CPK level usually it is increases in rhabdomyolysis like conditions.
Yeah, usually CPK is high in when the muscles are involved, maybe a myopathy or myositis or rhabdomyolysis or any poliomyelitis, dermatomyositis. Those things, though, in those conditions, the CPK levels can be high, right? but here not in Guillain-Barré, right? Or the Miller Fisher. Yes. Okay, we go to the next thing. Uh, yeah, 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 you are like a so, yeah. You are like a GP, right? ඔය අර පෙරිෆෙරල් වල GPs ලා නම් ඕක කරලා එවනවා. paracetamol suppository එකක් ගහලා එවනවා. Right. So the child is still conversing, no? Another conversion. So conversion has not stopped yet, right? It's going on. So fever for 1 day and 1 episode of conversion during physical examination, he developed another conversion. That means there's another conversion, right? And temperature is high and ABC is they have done. The next thing is the disability and the exposure. So what do we do in disability? Are we administer paracetamol? Huh? Yeah, anyway, we have to stop the conversion, right? Because if the conversion is going on, then the child brain can be hypoxic and he can be die, right? And there can be a permanent brain damage. So idea is to stop the conversion now because they have done the initial ABC. So paracetamol suppository, there's no place in febrile conversions, right? I mean, paracetamol suppository එකක් දානවා කියන එකකින් we can reduce temperature, but we can't do anything for the conversion, right? So tapid sponging now no more, it's not done. And monitoring vital signs and observe, no, we can't just again conversion again so we have to stop the conversion. So we are running with buccal midazolam and buccal diazepam. So what is the first line anticonvulsive agent in pediatrics? Yeah. So yeah, pairing තාම කවින්න ඉන්නේ අර මේ old era කියන්නේ. So we don't, if we don't have what IV access, we don't go with the what rectal diazepam, right? Now we have buccal things, right? Buccal lorazepam, buccal midazolam we can use, right? ඒ දෙකම use කරනවා, right? It's available in our country now. So yeah, buccal lorazepam or buccal midazolam or IM midazolam we can give, right? So buccal diazepam එකක් තාම නම් නෑ, right? හොයාගෙන නෑ. So maybe in future, but here what we do is buccal midazolam or lorazepam or IM midazolam, right? Okay. Yes,
Sir,
Pauline.
next question. Yeah. Next question, I'm Aisha here.
Yeah.
A 3-year-old boy presented with unsteady gait and slurred speech for 1 day duration. He had
Yeah.
upper respiratory infection with a generalized vascular rash 3 days ago. His CT is normal. CSF is normal except for mild elevation of protein. What is the next step of management? So in this boy, as he has having unsteady gait and slurred speech, I think it's more suggestive of a cerebral lesion. And as he has got a generalized vascular rash, it could be more suggestive of varicella. So I took it as post-infectious cerebritis, most probably. And
Yeah.
so when considering next step of management, out of all the options, I thought it will be best to start with a IV acyclovir.
Yeah. Good. Right. Yeah. Yeah. Very good. Yes. Unsteady gait and slurring of speech. That means there's a cerebellar involvement, right? So child has had upper respiratory with generalized vesicular rash. So post cerebellar, post infect, sorry, post sign in a acute cerebralitis. The common thing is the varicella infection, right? But it could be due to the other viral things as well. Any things could be adeno, could be para-influenza, or any other thing can cause. But the commonest thing is the varicella infection. So they can have acute cerebralitis. So what we have to do is to give IV acyclovir, right? Yeah, good. Yeah.
I'm now there.
Yeah.
2020 June 29th question. 12-year-old boy admitted with a history of collapse while playing. According to his friends, he had complained of a severe headache and vomited once prior to the collapse. He gives a history of having on and off headache. On examination, he is afebrile, unresponsive, and has neck stiffness. His blood pressure is high, and the pulse rate is also fairly high. His pupil size is 5 with a sluggish reaction to the rat. In the answers, I excluded cerebral abscess because he doesn't give a history of fever.
Yeah.
And then
Good. Yeah.
answer D, subdural hemorrhage is unlikely in young population. Then because the history gives
So what is common? What is the common age group to get subdural hemorrhage?
elderly it's more common, but I
Yeah,
can't say no.
elderly with alcohol, right? So alcohol substance abuse, yes, they can have subdural hemorrhages, but no here 12 year. Yeah, we can't say no, but yes, it's rare, right? Okay.
According to the question, I think the keyword is neck stiffness.
Yeah,
Neck
good.
stiffness when there is something in the cerebrospinal fluid which irritates the meninges. And
Yeah.
so, considering the answer C, when subarachnoid hemorrhage occurs, blood goes to the cerebrospinal fluid and irritates the meninges, the neck stiffness.
Yeah.
I think that's the most relevant answer here. But I'm not able to explain why the blood pressure is high and why the pupils are sluggish. But I think the answer is
Yeah.
C.
ඒක පොඩ්ඩක් එතන මේ ඉන්ෆෙක්ෂන් එක පොඩ්ඩක් එතන මිස් ලීඩ් වෙනවා නේද එතන. Yeah, blood pressure is high and pulse rate should be then low, right? එතන එකත් tachycardic කියලා දීලා දිනවා and pupil also it's 5 is sluggish reaction. Explain කරන්න බෑ, but yes, sometimes we can explain මොකද orbital artery එක හරි එක වුණා නම් සමහර විට වෙන්න පුළුවන්. Right, pupils එක, but we can't explain high blood pressure with tachycardia, right? It's very rare to have, right? There should be high blood pressure with low pulse rate. Yes. So what is the answer is correct, and the keyword is, as she mentioned, it's the neck stiffness, right? So in a child with neck stiffness, first thing is the meningitis, but here the meningitis picture is very unlikely, so it has been there for some time on and off headache and sudden onset of severe headache. So that is more towards subarachnoid hemorrhage. Yes. So what could be the cause? What is the commonest cause for the subarachnoid hemorrhage in children?
AV malformations.
Yeah, good, right? Very good. Yes. Yeah, that is the arteriovenous malformation is the commonest reason to get subarachnoid hemorrhages in children, not the other causes. So we have to do the so what is the investigation that we do to diagnose subarachnoid hemorrhage? And if you are still suspecting AV malformations as well, what is the
Brain.
CT what?
Brain.
CT brain it's like an umbrella, right? Umbrella term, right? It could be non-contrast CT, it could be contrast CT, it could be contrast CT with angiogram or anything, right? So, yes. With that, what could be the answer?
Contrast enhanced CT with angiogram.
Yeah. CT with angiogram. So we can do a CT angiogram, right, of the brain. So we can see the circle of Willis, right, and we can spot the AV malformation, and we can diagnose the site as well. So what we do is the CT angiogram, right? MRI or nathang the if we are in a high, I mean not here in Sri Lanka, but if they have given MRA, that could be the answer, right? Magnetic resonance angiogram can take a product specific, right? Okay. So anyway, in a child with subarachnoid hemorrhage, if we do the LP, what do you expect? What is the typical uh, uh, CSF color in subarachnoid hemorrhage? There's a name for that.
Xanthochromia.
Yeah, good, right? Yeah, that is xanthochromia, right? So we will check. We will see xanthochromic CSF sample in child with CH, right? Yeah, good. Yes, we'll go to the next thing.
So I'm Aisha here. A 4-year boy had a quarrel with another child in the classroom and fell down, following which he developed sudden jerky movements that settled on its own. Teacher took him to hospital and mother revealed that there was a similar episode following MMR vaccination at 3 years, most appropriate management option. This I couldn't come to a very definite conclusion, but I think after MMR vaccination, having a seizure would be most probably a febrile seizure. But in this child, as he has fallen down, maybe we should assess whether there have been a head injury. So I thought better to go for a contrast enhanced CT scan, but I'm not sure.
Himalayan not sure right? So you are in the professorial unit now, and you have done 2 pediatric appointments, and one with us, and one in Candy. So you have to show your colors now, right? Yeah. Any other answer?
Also, I thought sometime this could be maybe a reflex asystolic syncope. I'm not very sure.
You are creating diagnosis. new diagnosis, right? Yeah. So anyone, yes. What could be the possible diagnosis here first? Come on.
This could be a reflex and
Yeah, good, right? Yes, this is reflex anoxic seizure, right? Usually, when they have some emotional things like maybe crying, maybe excessive laugh, or maybe emotional things like any emotional trauma, psychological trauma, they can develop all of a sudden conversion. But what we call is reflex anoxic seizure, right? There are two types. One is the palate type, other one is the non-palate type. Palate type එකේදී they will get cyanosis as well. But here the typical presentation of reflex anoxic seizure. MMR එකෙන් පස්සේ ඇවිල්ලා තියෙන්නේ because of the vaccine. Usually sometimes they can have reflex anoxic seizure because of their fear to get the vaccination, right? So the answer is reflex anoxic seizure. So what do we do for reflex anoxic seizure? Do we do anything?
just reassure the mother.
Reassure the
Yeah,
mother.
yeah, reassure the mother. But for the ones who have read it very carefully, there's one association with the reflex anoxic seizure. So we have to exclude that thing. Exclude means we have to treat for that thing because there's a correlation between reflex anoxic seizure and that condition. What is it? ඔය පැතුම් සෙහිම හරියට අහන ප්‍රශ්නයක්, right? So in a child with reflex anoxic seizures, we have to exclude iron deficiency anemia, right? They have found that there's a correlation, that means coexistence between reflex anoxic seizure and iron deficiency anemia. So in a child with reflex anoxic seizures, yes, we have to reassure the mother. At the same time, we do full blood count and blood picture for the evidence of iron deficiency. If it is there, we will treat iron deficiency with iron, all right? Yeah, that is the complete text of reflex anoxic seizure, right? ඔය ටික දැනගන්න ඕන, right? Clear නේද? Are you all clear? Kavindu? Clear නේ? I'm asking Kavindu because he's the host here, right? Yeah. So go and read about reflex anoxic seizure. Final එකේ අනිවාර්ය section එකක් එනවාමයි. Could be true, false, could be best of one, right? Okay, එකක් කොහොමද දාන්න, right? Okay.
I am Hasna.
Yeah.
My question is: a child presented with fever, headache, and he was drowsy. CSF report as follows. This is a clinical feature suggestive of meningitis. Then they taken the lumbar puncture. The lumbar puncture results came as cell count shows high lymphocyte count and proteins mildly elevated, glucose almost normal.
Yeah.
In the answers, if we get the if we look for the answers, if we get the autoimmune encephalitis, usually the protein count will be high, and also the cell count may be normal or slightly elevated.
Yeah.
But in this condition, the protein is mildly elevated, so I exclude the autoimmune encephalitis.
Yeah.
And also in partially treated bacterial meningitis, even it's a bacterial meningitis, the cell count could be neutrophil, high neutrophil count, but in this case, the lymphocyte count is high. Therefore, it can't be as partially treated bacterial meningitis.
Yeah.
So I exclude C as well.
Yeah, one more thing to add. Yeah, one more thing to add. In partial treated meningitis, there can be lymphocytes as well, right? When the condition is partially treated, lymphocyte can cell count can be high, right? So it's a mixed picture of neutrophils and lymphocytes in a child with partially treated meningitis. Right. Okay.
Yes. If we take TB meningitis, then the cell count may be high. The lymphocyte count may be high, usually high, and then the protein also high.
Yeah.
But if we consider the glucose, it's usually low. But in this case, it is normal. Therefore, I
Yeah.
exclude TB meningitis as well.
Yeah, one thing to add, in TB meningitis, glucose can be normal or low, right? Both can be happen, and but TB meningitis, protein levels are very high, right? Protein levels are not mildly elevated; it is very high. At the same time, there can be some lymphocytes, and glucose can be normal or low, right? Sometimes, if there's a severe TB meningitis, glucose levels can be low, right? Okay.
If we take the option E, it's a viral encephalitis. In
Yeah.
case of viral infection, the cell count usually shows high lymphocyte count.
Yeah.
Then the protein can be mildly elevated, and also glucose it can be usually in the normal range. Therefore, I go with the answer E, viral encephalitis.
Yeah.
In the option A, disseminated meningoencephalitis. I'm not sure about whether there's a disseminated encephalomyelitis. That is.
Yeah, usually, disseminated meningoencephalitis, it could be bacterial or viral, right? So, disseminated meningoencephalitis means it's a very disastrous thing. If there's a severe viral or bacterial things, or could be due to the autoimmune things as well. There can be a disseminated meningoencephalitis. So, there are usually the bacterial count is high, right? I mean, it's mainly because of the bacterial pathogens, right? Not it can be due to viral, but common thing is the bacteria. So they will get the bacterial picture, right? Yeah. Answer is E, that is viral encephalitis that shows protein levels are elevated, mildly elevated than lymphocyte count and glucose count. Yeah. So if they have given red cells as well, so what do you think? What could be the possible viral etiology?
Herpes
They have
simplex,
given.
herpes simplex virus.
Yeah, herpes. You have to think of herpes. So, what are the other, supportive investigations that we can do if we are suspecting herpes encephalitis?
We can do a PCR of the CSF.
Yes, yes, we can do, but more simple thing. ඕක මම දැන් පළවෙනිම MCQ discussion එකෙත් කියලා දුන්නා. Right? Anyone can remember? Yeah, in herpes encephalitis, what will happen? Usually, there's an involvement of the parietal region, right? So it's a focal involvement. So we can do EEG, right? So we can see what spikes in the temporoparietal region. So that is one of the supportive investigation that we can do, right? Yes, we can do PCR for herpes, but it's a high-fi thing. So before that, we can do the EEG and see the focal involvement, right? Okay. Yeah. Next thing.
Sir, I am Pabasara.
Yeah.
Sir, my question is 8-year-old boy presented with recurrent falling for 6 months duration. He had big
Yes.
sinus walking. On examination, bilateral ankle reflexes were absent and there was a sinus in the lumbar spine region. What is the next investigation? He has recurrent falling for 6 month duration, so there should be lower limb weakness and there is bilateral ankle reflexes. Bilateral ankle reflexes are absent.
Yeah.
It looks like there is a spinal cord lesion. There is a spinal cord lesion, so it can be due to the sinus in the lumbar spine region due to the extension of that sinus tract.
Yeah. Yeah.
So to visualize the extension of the sinus tract, the best investigation is MRI lumbosacral spine. The answer is B. Sir,
Yeah. Are you sure? And Papa sir, are you sure with the answer? Go there.
not sure, sir.
අන්න ඒකනේ කියන්නේ.
Not sure, sir.
You're correct, right? Anyway, right? Your answer is clear. I just want to know whether
Not
you
sure,
are
sir.
why not sure? Yes. So where's the screen? Yeah. Can you all hear me? ඇහෙනවනේ? Yeah. So yes, you are correct, right? So doubt එකකින් ඉන්න බෑ when examiners sometimes they will ask like that. Are you sure? Are you sure? Then you can't change your decision, right? You have to say yes, right? Anyway, yeah. Yeah, he has mentioned. Yeah, yeah. His answer is correct. Yes, the child has had some recurrent falling and equinus walking as there should be a nerve involvement, nerve trapping or anything, and bilateral ankle reflexes were absent, and sinus is there in the lumbar region. So the best thing to visualize the site is the MRI, right? So we have to do the MRI lumbosacral spine, and here where's the lesion here? So with the clinical what findings? Yes, Pausar, where's the lesion? Ankle, bilateral ankles absent. So where could be the lesion there? Yes, Kesher, where's the lesion? The bilateral ankles are absent. Come on.
S1 is 2.
S1, S2. Are you sure?
Mainly S1s.
ඇයි මොකද mainly S1 වෙන්නේ? Ankle reflexes වල මොකද්ද මේ lumbar site එක? S1, S2 ද? Is that S1, S2? There are specific, sites නේ. Knee එක, knee joint. What is it?
L3,
L3, L4.
Yeah, L3, L4. Yes, right. And ankle?
S1, S2.
Are you sure? S1, S2 or L5, S1? Maybe I'm confused now. Is the ankle
S1,
S1 is huh?
S1, S2.
Are you sure?
Yes.
Okay, right. I can මටත් පැටුණා. As far as I remember, that is L5 and S1. Anyway, I will cross check it. S1, S2. Ankle letter. Anyway, right. Yeah, you should know, right? Ankle, what is it, and what is knee, and what are the other things? Me elbow sleeve ඔක්කොම දැනගන්න ඕන, right? Okay, right.
So the next question, the child is having drowsiness and neck difficulty in retraction, CSF
Yeah.
short lymphocytosis and sugar low. Few vesicles in chest, probable causative organism is asked. Here, it is suggestive of a CNS infection where CSF lymphocyte counts are high and the sugar low. So this could be a picture of viral meningitis or encephalitis or a TB infection, but it tells that there are few vesicles in the chest. So I went with the answer as the varicella encephalitis, as because of it tells that there are vesicles in the chest. So I took the answer as D.
Yeah, you answer. Yeah, it's a simple thing. Yeah, that is answer is D. That is varicella encephalitis. What is cryptococcal meningitis?
So it's a fungal infection in the meninges.
Yeah, it's a fungal infection, right? Yeah, good. So if you are suspecting fungal infection, how long do we have to treat fungal meningitis? There are duration of treatment. It depends on the organism. So if it is pneumococcal, how long do we treat? If it is strep pneumonia,
No idea.
අන්න ඒක තමයි කියන්නේ. So when you are doing the frictions, you have to read around the frictions, right? Okay. So streptococcal pneumonia, basically we have to give 10 to 14 days, right? And Neisseria also, Neisseria meningitis, we have to give 10 to 14 days, but Hemophilus we can stop at 7. But usually hemaritum cut off to cover all we give 10 to 14 days. But if it is there's E. coli, we have to give it for 21 days. And for fungal things, we have to at least give for 42 days. Right? Okay. Yeah, 42.
Hello, sir. I'm doing the next question.
Yeah.
From Ashini. 4 years old child presented with convulsions, dyspnea, grunting. His saturation is 85. Heart rate is 80. What is the best step in the management? So the in the in convulsion, it's as an emergency. You have to care of the airway between and circulation. The grunting can be happen either by secretions or by due to the increased ICP.
Yeah.
But if the ICP is high, there have to be bradycardia. But as there is no bradycardia, I thought it can be a due to the secretions. But I'm not sure. The best answer would be suck out of the secretions. So give high flow oxygen.
High flow oxygen, right? Yes, we have to give oxygen, but first thing we have to do is the secure the airway, right? So to secure the airway, what we have to do?
Suck out the things in the
But
secretions.
Any other answer?
Oral airways.
Yeah, right. So in a convulsive child, we don't actively suck out the secretions, right? Remember that thing because එහෙම වුණොත් ඕක තව ටිකක් disastrous වෙනවා. We have to wipe out the face and we can wipe out the things that are in the outside, but we don't actively suck out the things. So what we do is to secure the airway, we put an oropharyngeal airway, right? So oropharyngeal airway එකක් දාලා we keep the airway patent, then we can suck out the secretions, right? එහෙම blindly නැත්තම් එහෙම අර NG එක දාලා suck කරන්නේ conversions තියෙන ළමයි, right? We do the oropharyngeal airway insertion, then we suck out the secretions, right? And then we can give oxygen as well if saturation is still low, right? Okay. Yeah, we can put, right? So we keep the child in the left lateral position, then we can put the oropharyngeal airway, right? We can do that.
So I'm doing the next question also.
Yeah, we'll stop from this, right? Okay, right. Now you will have, I can do, but neither. How will you? What do you think? No, I can do. Okay, කරා කියලා ඔළුවට යන්නේ නැහැ. දැන් almost it's 1.5 hours. Yeah. Okay, we'll do the thing, right? We'll do the last thing, yes. Ashini?
9 months baby presented with flexion movements in all 4 limbs, lasted for few seconds, appeared as bouts 14 to 20 times per day. He can't sit without support and cannot reach for objects. Neurological examination was normal, and there was a rash over the face, and EEG show hips arrhythmia. It asked what is the most suitable drug for this child. This is the same question we did, and I think it took it as West syndrome, sir.
Yeah.
So the treatment is vigabatrin.
Yeah. So we have discussed, no? Yeah. There's a child with tuberous sclerosis, right? There's a rash over the face and hips arrhythmia is there and developmental delay is also there, right? So what we can give is the vigabatrin as the drug. So what are the side effects of vigabatrin?
It causes irritability and reduce the visual fields.
Yeah, good, right? So they can have vision problems, usually night blindness and retinal blindness they can have. Yeah, the kahana, right? Vigabatrin side effects, retinal toxicity, right? So they can have color blindness or retinal change, right? Okay. Go and read about infantile spasms and tuberous sclerosis and West syndrome, right? What is kahana? Right? Okay, we'll stop there, ne? Right. Okay. Okay. All right.